This is the mitral valve, and basically, when we talk about valves, they either get stuck, they leak, or they do some of both. And you can see that that the screen on the far left is the normal mitral valve, and then on the far, your far right is a stenotic valve. That's a rheumatic valve, and there you can see a ventriculogram where the valve that leaks. So that's what we're talking about. And when we talk about mitral valve disease, and if we put in perspective, there's been a revolution for aortic valve disease in the past, 5-8 years in TAVR, and we've been seeing a lot of senile degenerative aortic valve therapies and patients being treated. And now we're looking at the next revolution, which is the mitral valve, which has even larger numbers than the aortic valves when you look at the patient population above the age of 75. So it's a complicated apparatus, especially compared to the aortic valve. There's an anterior leaflet and a posterior leaflet. There are chordae, there are papillary muscles that attach and tether the leaflets to the anterolateral and posterior medial walls, and there are commissures. There are even first, second, and third order chordae. So there are also the surrounding structures. And when you're talking about performing structural interventions, not only are you interested in the target apparatus, but all the neighbors to it. So again, this is the mitral valve through different perspectives. This is on the far left is a traditional surgeon's view. You can see the relationship between the left atrial appendage, the mitral valve. This is your anterior leaflet, your posterior leaflet, and the relationship to the aortic valve. This is what we call the aoromyotracheal curtain. And you can see this is that's a cross-section, a longitudinal axis of the mitral valve that's often seen in traditional echo views. And because of the surrounding structures, a lot of opportunities and challenges, so you don't harm or compromise nearby structures. And we'll talk about some of those things coming up, like the circumflex artery, the coronary sinus. You're very close to the fibrous contiguation to the aortic valve. And of course, you can see the continuity between the aortic leaflet, the anterior leaflet right here, and this is the left ventricular outflow tract, which is something that we've already mentioned in Dee's talk. Okay, so just briefly, traditionally, when people talked about mitral valve stenosis, it was most rheumatic disease. And since the advent of antibiotics, and modern healthcare has kind of almost eliminated rheumatic heart disease, but not completely. But a new entity has actually shown up, which is senile calcification. We'll show a case of that later. And this is what we were talking about when it comes to rheumatic heart disease. This is a inflammatory process, and then the valve has some fibrosis form. It forms at the commissure, so it makes this kind of fish mouth thing. It restricts the opening of the leaflet. And then there's been a long-standing therapy for this, which is balloon mitral valvuloplasty. But the more challenging entity in mitral stenosis is this new one that we've only seen more recently, or thought about treating more recently, which is senile calcification of the mitral valve. And you can see that the flow through the mitral valve is being impinged by the restriction of the opening. The mean gradient here was 17. So we thought about creative ways to tackle this problem, because there are, just like people with aortic stenosis, some of these people have some functionality, and they're desperate for some solutions. And we asked ourselves, well, if it's so calcified, can you put a valve in there? And as you can see in this view, this parasternal long axis view, that it's very crowded here, and we've had to come up with some unique solutions for that unique problem. So, just as a temporizing measure, we extrapolate from our prior experience and used a balloon to dilate the valve, and we were able to do it without incident. The valve doesn't leak that much after the balloon dilation. But something that we thought of is, well, can you carve out some of that muscle and make some space? And obviously, a lot of these patients are older. They're not ideal surgical candidates, just like some of our other structural patients. So here we've done a preemptive alcohol septal ablation. So this is part of a study that's being performed. It's a multi-center study being performed across the country. And Dr. Wang and her team have done a thorough analysis of, can you put a valve inside? What size valve does it have to be? What are the limitations? And this is after we've done the alcohol septal ablation. And you can see we've carved up a little bit more space, but there's still some danger because when you put a valve in here, it still may obstruct. So we have to do some precise calculations and take some risks or take some calculated risks, which will help work out in the patient's favor. Again, this is a 3D representation. This is really a planarized representation from the short axis view from the CT. And you can see this is the anterior leaflet. This is what's very common is you see this posterior ring of calcium, which is going to anchor the valve. So ultimately, it was decided that the patient was going to be a candidate, and the way we do this is just as Dr. Wang showed you, through simulated simulations in the CAD software, we're able to put an object that's to scale to the proposed mitral prosthesis and see how close it comes to the left ventricular outflow tract. Here's another representation again, giving you another idea of what you're dealing with. And in this patient, based on we have limited control of where you put the valve. Sometimes it's a little further ventricular, sometimes a little further atrial. But after going through a lot of calculations, we can give ourselves the probability it's going to obstruct and what our chances are, and what's the best way to deploy it. So here we are again, just figuring out what angle we should look at the heart with using the CT scan. And this is the left ventricular outflow tract, and this is what we think it's going to look like after we put the valve in and how much space is left. And based on that, we can understand, are they going to obstruct or not. And this is just another plan. Dr. Wang's preparing us in case we want to do an apical access. And, what would that look like? Where are we relative to the rib? And how safe is it? Okay, so here we are. This is game time. We're doing the septostomy here. And here's a SAPIEN 3 valve. And what we've done is with the rapid pacing run, we do a contrasted angiogram, take the prescribed viewing angle that Dr. Wang recommended, which was spot on, and had a successful deployment without outflow tract obstruction. So this is the rubber meets road moment, and it doesn't leak. And here's the prosthesis again. You can see it's a functioning prosthesis, which would decrease the gradient from 16 to about 6 millimeters of mercury. Now, I showed you the plan. In that case, we didn't use an apical rail, but in the cases we do, you can successfully cannulate the ventricular apex without doing a big cut down or a thoracotomy and exposure. And this is what we've done here is we've been able to access the LV apex with a needle. We put a sheath in to prepare us for this. We did like a coronary angiogram just to make sure we were safe. And this is what it looks like. And you can see it's just a small tube that's in the chest. And we use this access to help us deliver a valve in case we have a hard time and line it up. And so just so it looks like this. And here we're implanting a valve. This is a stenotic, a failed bioprosthetic valve. And again, kind of with the same process that we did before. We inspected, examined the left ventricular outflow tract and understood what our risk for obstruction was. And just in case you're interested, once we make the hole there, we do close it with this little nitinol device that's made by St. Jude Medical. All right. Okay, I guess that was supposed to play, but it didn't. Anyway, if that was moving, you would see that was a valve leak, and we're just going to talk about mitral regurgitation. And mitral regurgitation, it's pretty complicated. Well, because there are a number of things that come into play. The pathology of the leaflets and some of the ventricular pathology all interact and determine how much you leak. So you can see there's lots of different ways that your mitral valve can become diseased. You could have a floppy valve that instead of stopping at a certain point, flips backwards and then lets the blood through. You could have rupture of the cord and you have the same problem. Your valve could be dilated, and then because the muscle is being pulled apart because it's dilating, it doesn't let the leaflet come in. You could have a rheumatic problem, which is where the leaflets are diseased and fibrosed and it shortens. So those are all important considerations. But to simplify things, we've kind of separated out into a few main categories, which is degenerative, which is either prolapse or flail, or functional mitral regurgitation. So, and it turns out there's a lot of these patients that you can see get or not operated on. This is actually some local data. I think this is published out of our friends at University of Michigan. And you can see that almost half the patients that are presented, 112 patients, were not operated on for multiple indications. So again, as the tired phrase goes on, the unmet need is there. This is the rationale, and a lot of it's due to comorbidities, but some talk about stable chambers, but there's a variety of reasons for why these patients didn't get operated on. And when we're talking about devices for treating mitral regurgitation, again, there are a lot of therapeutic challenges. The mitral valve is saddle-shaped, it's D-shaped. Where are you going to fix a valve to? It's not like the aortic valve where it's a tube and it's calcified all the time. How are you going to seal it so it doesn't leak? What about this annular LV cord interaction? There's some role for the tethering and the papillary muscles being present and pulling the muscle in to the annulus. And some of these adjacent structures are very relevant, and how durable are the valves going to be. So these are kind of like the devices that have been in development for treating the mitral valve. You have annuloplasty from the coronary sinus. You have direct annuloplasty, which is that tissue around the valve annulus. People are implanting things into and trying to close the gap and bring it in. There's the MitraClip, which has been around for quite some time. Chordal shortening, mitral valve replacement, which is a new entity. And I'm not going to go through all these, but this is just an idea of what's the breadth of technology out there being developed for a mitral valve. So we'll talk about the MitraClip very briefly. It's based on a technique that Otto Alfieri created, where instead of doing a lot of things with the mitral valve annulus, you just put some stitches in the middle and saw if it could treat the mitral regurgitation. So some inventive people extrapolated this and said, well, why can't I just create a little arm that clips the valve? And that's what we've just done. And there are some limitations. Mostly right now in the United States, it's approved for degenerative MR, like the valve should prolapse or it should have some flail. But there are some things it can't do, and which kind of segues into our other technologies, like if the coaptation length is short, or the depth is too long, if there's a big flail gap, or the width of the flail is very big, then you have some challenges to putting these clips in. So this is data from the EVEREST 2 study. It's a few years old now, and what they saw was there are some limitations to doing the percutaneous repair compared to surgery, and you found that a lot of these patients did end up having to go back and get some kind of mitral surgery or operation. But what I think is so funny about this table is if you compare the amount of severe MR afterwards, it's actually the same as the surgical ones, but somehow these all got repaired and the surgical ones didn't. So I'm not sure exactly what happened there. All right, and kind of the same thing. In fact, look, if you look at surgery and how much leaking there was between the clip and the surgery, it's the same 4 years afterwards. All right, so I talked about treating mitral regurgitation, mostly degenerative, with the clip. There are some people that are treating functional MR, mostly in Europe. There was a randomized study in the United States for it, so we can't say that we do that yet. But what I just wanted to show you guys was it does work. Maybe not as well as some other things may, but these patients were able to have reduction in their mitral regurgitation and as a result, they did have remodeling of the LV chambers. So just stay tuned. And this is just an example of a case. It's a complicated case. This is a patient with 2 jets. And what we did is we clipped the area around each jet independently. And in doing so, we're able to cause a significant reduction of the mitral regurgitation. The patient was symptomatically improved. And this is just like a 3D rendering. So, we're 3D all the time. So here, this is, Dr. Wong, she's helping us with the 3D echo. This is the anterior leaf and the posterior leaflet. And just, it gives us a better understanding of our spatial orientation and relationship between where we were and where we are. It helps confirm that we're doing the right thing. It takes a lot of practice and training for this. You have to know what you're seeing and see what you're doing, and sometimes they're not the same thing. Anyway, well, some people have criticized this technique because they saw Otto Alfieri's data. They said, well, how can the MitraClip work? Look at what it did in surgery. The results are terrible. But if you look at this is I think the 4 or 5 year data that was published presented recently, and they see that the MitraClip, after you get through the initial stage when some of those people had revisions, that once the clip is in, and this is a 6-month landmark analysis, that the results are durable. And I think the reason it's different is because instead of what Otto Alfieri was doing is, we're clipping where it leaks, because we can see the heart's moving. Otto Alfieri had to take the patient, on pump, reduce cardioplegia, the heart's frozen, and you can't see what is really going on, and he just puts a clip in the middle no matter where it leaks. So I think this is probably why the MitraClip is better than the surgical Alfieri technique. Moving on from that, there's a lot of technologies that are trying to use the coronary sinus to try to bring the area in so that the leaflets can go out better. So this is one example of a device that's been around for a while. It's called the Carillon. And what you can see is it does cause changes in regurgitant volume and makes the leaking less. And also, you can get reasonable results. What's tricky about this type of technology in the coronary sinus is there's a significant interaction of the left circumflex to the coronary sinus. This is just another system called the ARTO System. And what it does is this creates a tether here, and it decreases the septal lateral dimension so that it brings it in, but instead of in a round way, just a linear way. And their initial data of 11 patients showed reasonable results with reduction in mitral regurgitation in most patients. So it's still early data, and this is what I was talking about, is the circumflex is deeper than the coronary sinus 60% of the time. And as far as when you're using the coronary sinus, you understand that depending on where you put it, it has a different distance from the sinus as far in different parts of the mitral annulus or the circumference. So if you're on the medial part around P3, it's 5 to 17 millimeters away. But if you're a little more posterior, then it's not. It's closer. But it just tells us that there's some limitations to using the coronary sinus. Well, some people saw that and they developed another technique. This is the Cardioband procedure, and similar to the MitraClip, you go across the atrial septum and you implant these. You screw in and you plant these tethers in, and then after you do this, you can cinch it down and increase or decrease the area of the mitral valve. So that is being developed. It's being used in Europe. It's a pretty rigorous procedure. It takes a lot of time and it takes a lot of careful imaging. But we'll see if it's coming to the United States. Actually, I think there's some being done. I think Baylor is a site, and they're implanting some in Texas. And again, early results show that it's mostly positive, but it's still pretty early. Although their cohort's a little bit bigger. It was 45 patients. This is so we've talked about the annulus. We've talked about repairing at the leaflet level. This is another repair at the leaflet level, simulating a cord. It's a Babic leaflet puncture. And you have you have a pulmonary vein here. This transapical access. You puncture a leaflet, and you snare from here, and you just bring cords down to create a neocord. So we'll see how easy this is to do. It's still in clinical development. I'm not sure if human cases have been done. Well, that was all about repair. But recently we learned something about mitral valve repair, and it's got limitations in certain disease groups. This is these are people who had surgery and they had valve repair versus replacement in ischemic mitral regurgitation. And what they found was that if those people got repaired, they did a lot worse. There was more mortality, and there was more subsequent mitral regurgitation. So what we're learning is repair for certain diseases does not work as well as possibly a replacement. And in sight of that kind of information, people are looking at all sorts of ways to deliver valves. There's transeptal, which has been very alluring. Transapical seems like the simplest. There's the morbidity of using the ventricular apex. Some people have talked about transatrial. And this kind of like retrograde one, it seems really hard. I'm not sure how viable that one is, but we'll see. And this is just an example of how would you do a direct atrial access from the posterior side. Do some kind of mini thoracotomy in posterior or posterolateral in order to access this Waterson's groove. So, I'm just going to briefly go through some of these valves, but the bottom line is there are multiple valves. Most of them are being delivered transapically, but they have different facets to them, like different ways to affix themselves. Like this valve, Fortis has paddles to affix itself to the mitral annulus. So you can see that it gets implanted, and these paddles come up and capture the annulus to secure the valve. But one of the limitations is, look how long this is, and if you have a small cavity, then you're going to have issues with left ventricular outflow tract obstruction. So this is a Tiara valve. I think the Vancouver group has been implanting this for the past couple of years, and it's implanted through the apex, and here it's a self-expanding valve, and you just kind of like let flower and plant itself. And this is just like a short series. Then this is shown it just last fall. And then here there was only 7 implants, so I'm not exactly sure why the clinical development is so delayed. The first publications were in 2014. This is the only valve, or the only valve that can be implanted through a transeptal axis so far. This is cardiac Q, and this has been in clinical development for some time as well. It also has a transapical mechanism for delivery. And Tendyne, so this is very near and dear to us. This will be a site. There's about, I think, less than 10 U.S. sites implanting this valve. It requires a transapical access. It's a D-shaped self-expanding valve, and it has a tether to the apex, which is a little bit unique. And it's repositional, retrievable. So we'll be enrolling patients for both degenerative and functional mitral regurgitation coming up. And these are just some of the 30-day outcomes. And what you see is, all 10 of these patients live, and this is just some European data, and they had good results with respect to decreasing the leak. So, it looks promising. So, I don't know if this is a busy slide, but this shows us some of the technology that's out there and who it's coming from. So, Edwards bought cardiac Q, and I think this is the only one with transvenous access. And the remainders are all transapical. And some of them have asymmetric frames, and some of them have symmetric frames. And there are a variety of ways of fixing them. So cardiac Q uses tabs and paddles as a flange. Tiara has a flange and paddles. So is Fortis, but Tendyne doesn't, has the apical tether. So we're still learning what technology is going to work. Anyway, in summary, there are some established technologies like the MitraClip, and you can consider coronary sinus annuloplasty. I know Dr. Greenbaum is, in partnership with the NIH, is working on mitral cerclage, which is another technology that uses the coronary sinus for annuloplasty, and we're looking forward for when that technology becomes available for humans, but it's in clinical development right now. Some emerging advances for replacement and repair. And the bottom line is advanced imaging is key to implementing new technology. This is kind of an old slide for me, but structural interventions are unique compared to what had been going on up to like the early mid-2000s, is because vascular structures are constrained, and there's only so many ways you can go before you start going outside the vessel. And in order to know what you're seeing and see what you're doing, 3D is extremely important to the key to success. So, the structural heart disease group, owes Dr. Wow and our team a lot for our own success, because it's really, the planning is what makes everything possible. You find that doing procedures is only maybe 15% of the work, but it's the planning is really what gets you through the case safely.